Hello all. I'm here to talk to you about, or rather, I would say, discuss about the periodontal ligament. So let's directly go to the topic. So, what the required contents for the periodontal ligament will be the definition, the shape of the periodontal ligament, the components which comprise the periodontal ligament, the principal fibers, functions, the neurovascular supply, lymphatic drainage, the theories which support the periodontal ligament, and the age changes, the clinical consideration, and the recent advances, or rather the science transfer, what we have come to know about the periodontal ligament recently. So let's see what the periodontal ligament is all about. We know that the normal periodontium usually provides the support which is necessary to maintain the teeth and function. It consists of three principal supporting components, which include the periodontal ligament, cementum, and alveolar bone, with the encompassing gingiva. So we can define the periodontal ligament as a complex vascular and highly cellular connective tissue which surrounds the tooth root and it connects it to the inner wall of the alveolar bone. So here in the figure we can see that the periodontal ligament is in the shape of an hourglass. So we know that an hourglass is narrow in the middle and broader at the coronal as well as the apical end. So here the periodontal ligament has a similar shape, and the dot here denotes the fulcrum of rotation. That is when there are excessive stresses acting on the periodontal ligament. It helps in the movement of the tooth within the physiologic tooth movement. And the width of the periodontal ligament usually is approximately 0.25 millimeter, the range between 0.2 to 0.4 millimeter. And we also see that there is a progressive decrease in the thickness of the periodontal ligament as age progresses. So coming to the development of the periodontal ligament. So here we see the structure depicting both the alveolar bone proper as well as the root cementum. Here we see the fibers arising from both the alveolar bone proper as well as the root cementum, and they both we see, and the rate of growth of the ligament fibers from the alveolar bone proper is usually at a higher rate compared to that of the fibers arising from the root cementum. The two fibers anastomose to form the future periodontal ligament. We shall now see how at what time the different fibers of the periodontal ligament arise. So this is a diagrammatic representation where we can see how a tooth erupts from the socket during the development of the tooth. So immediately after the eruption, the fibroblasts usually align obliquely along the long axis of the tooth, and the first formed fibers are the alveolar crustal fibers, which occur or rather develop at the coronal third of the tooth and at the first occlusal contact. That is, as soon as the tooth comes out of the gingiva, the horizontal group of fibers form and they occupy the coronal third of the tooth structure, and a definite occlusion, that is when they meet the opposing tooth, the tooth in the opposite arch, the oblique fibers or the oblique fiber bundles start developing or they are formed, and the last fiber to develop is the apical fiber, because as we all know, the apex of the root develops in the end. So thus the definitive periodontal ligament architecture is established. And we also have another group of fibers, that is the interradicular fiber, which is usually seen in multi-rooted teeth. Okay. Then when you section the tooth longitudinally, we find that the periodontal ligament has a wavy course. And this is the picture depicting the microscopic picture of how the periodontal ligament appears when viewed with the microscope. And also radiographically, we find that the periodontal ligament has a radiolucent area which ranges between 0.4 to 1.5 millimeter. And this is found between the radiopaque laminar dura of the alveolar bone and the cement. Now coming to the cellular components, We can divide the cells of the periodontal ligament to different types. That is the formative cells, resorptive cells, progenitor cells, epithelial cells, immune system cells, and cells associated with neurovascular elements. So coming to, before that, let's also discuss about the extracellular components of the periodontal ligament cells, which include fibers, comprised of collagen fibers, elastic fibers, and the ground cells. The collagen fiber group, we have the principal group as well as the secondary group, and the elastic group, we have oxytocin and alanine fibers, and the ground substance is composed mainly of 70% of water. It also contains glycosaminoglycans, proteoglycans, and glycoproteins, which include fibronectin and lamin. Now coming to the first category, that is the formative cells. The formative cells include the fibroblasts, the osteoblasts, and the cementoblasts. Now, what are fibroblasts? Fibroblasts are actually large multinucleated cells which occupy the which are usually seen which are the predominant cell group, the periodontal ligament, and they are usually flattened, irregular, disc-shaped cells with extensive cytoplasm. The main function of the fibroblast is production of ground substance as well as formation of extracellular matrix. Besides a formative function, the fibroblasts have a special function of not only formation but also resorption. That is, they maintain the cell ratio. That is, they have a dual function of both formation as well as resorption function because they secrete the collagenase enzyme and help in phagocytosis of cells. These fibroblasts are known to be the main source of type 1 collagen. Now coming to osteoblasts. Osteoblasts are cuboidal cells with a prominent round nuclei at the basal end of the cell, and these cells usually line the tooth socket, and they contain rough endoplasmic reticulum, mitochondria, and usually basophilic in nature, and they contact each other through desmosomes or tight junctions. Then the next formative cell is the cementoblast, and they line the surface of the cementum, and they are usually cuboidal, again cuboidal in shape, and are usually found to help in the protein synthesis as well as secretion. And these cells help in the formation of both cellular as well as acellular cementum, besides contributing to formation of periodontal ligament. And also they are found to be receptors of growth hormones as well as epithelial growth factors. So coming to resorptors, as we have already discussed, the fibroblasts are also have the function of resorption. Besides fibroblasts, we have other resorptor cells which include osteoclasts and cementoblasts. So what are osteoclasts? These are large multinucleated cells which occupy Cauchy's lacunae. These are lacunae found in the ostium or the alveolar bone, and they have a plasma membrane with which is raised to form a ruffled border or a striated border, and they mainly help in bone resorption. Whereas cementoclasts are found in depression in the cementum, similar to that of Cauchy's lacunae, and they are again mononuclear or they contain mononuclear or multinuclear giants. And they help in destruction of dentine as well as cement. So coming to epithelial cells. Epithelial cells mainly consist of remnants of earths with epithelial root sheath, and they are also known as epithelial rests of Malassez, and they are named after Malassez, who first introduced them to us. Malassez noticed these cells in 1884, and they are actually found abundantly in the furcation area, apical area, and cervical areas of tooth. And they usually appear as cluster-like ducts with cells separated from the surrounding connective tissue by basal lamina. They are again cuboidal cells with prominent nuclei, and when these cells undergo calcification, they are also known as cementicles. So coming to the fourth group of cells, that is the progenitor cells. These are cells can undergo mitotic division when they are stimulated. This could be an orthodontic movement or when there is any trauma or wounds. They are usually located in the vicinity of blood vessels, so they have a rich nutrient supply and they are capable of sustained renewal and tissue regeneration. They help in repair and differentiation of cells. That is, they are capable of differentiating into any type of cells. That is, it could be a cementoblast or osteoblast or a fibroblast. Then the next group of cells, the immune system cells, which we are already familiar about, which are mainly responsible for the defense of our body, which includes the neutrophils, lymphocytes, macrophages, mast cells, and eosinophils. Now, coming to the extracellular components, which includes the collagen fiber. The smallest unit of the collagen fiber is known as the fibril. Now, a number of fibrils together constitute to form the collagen fiber, and these group of fibers together constitute to form a fascicle. The collagen fiber, which is found most abundantly in the periodontium, is the type 1 collagen, which contributes to about 70% of the total collagen content, and the type 3, which contributes to around 20% of the fiber content. Besides, we also have the type 5 and type 6 collagens, which are found in very small or rather trace amounts. Also, we have the type 4 collagen fibers, which help in maintaining the integrity and elasticity of the extracellular matrix. And the type 12 collagen fiber develops only when the tooth is fully functional, or rather, when the tooth comes into occlusion. Coming to the principal fibers. So the principal fibers can be divided into 6 types. They include the transversal, horizontal, apical, alveolar crustal, oblique, and interradicular fibers. So the picture clearly depicts the different fibers and their location. The transversal, as you can see, is located near the alveolar crustal region. The alveolar crustal and the transversal are located in the cervical portion of the tooth. Then the horizontal at lower level in the oblique, which constitute the main periodontal supporting fiber, and the apical fibers found at the apex, and the interradicular fibers seen in multi-rooted teeth, that is between the roots of teeth. So coming to the transeptal group, they extend interproximally over the alveolar bone crest and are embedded into the cementum of the adjacent teeth. That is, they arise from the alveolar bone crest and they are embedded into the cementum of adjacent teeth. Then the alveolar crustal group, they extend obliquely from the cementum just beneath the junctional epithelium to the alveolar crest. They run from the cementum over the alveolar crest to the fibrous layer of periostin covering the alveolar group. The main function of the alveolar crustal group is to prevent extrusion of tooth and to resist the lateral tooth movement. The horizontal group fibers, they extend at right angles to the long axis of the tooth from the cementum to the alveolar bone, and they mainly help in resisting the tipping forces. They also prevent the lateral movements of the teeth. The oblique group, which is the largest group of fibers, they extend from the cementum in a coronal direction and they are usually seen obliquely. And they bear the brunt of the vertical masticatory stress. That is, the maximum stresses are borne by these oblique group of fibers and they transform them into tension on the alveolar bone. Now coming to the apical group, the apical group, they are usually found, as the name suggests, found in the apex of the tooth, and they do not usually occur in completely formed roots, and they may be help in resisting the tipping forces and luxation forces, and they help in providing a casing, or rather protect the blood vessels and nerves of the periodontal ligament. Now coming to the interradicular group, they fan out from the cementum to the tooth the perforation area of multi-rooted tooth. So they are found between the roots of multi-rooted teeth, and they resist the tipping forces, stopping forces, and the luxative forces of the tooth. Coming to secondary fibers, these secondary fibers are usually seen between the principal fibers. They are again located corona apically, and the elastic fibers, which is supplied by oxytocin and elongate, and the indifferent fiber plexus, which is small collagen fibers that are seen in association with the principal fiber. So with that, we come to an end of the different periodontal ligament fibers. Now, coming to the functions of the periodontal ligament. The functions of the periodontal ligament can be divided into 4 types. That is the physical function, formative and remodeling function, nutritive and sensory function, and regulation of the periodontal ligament. Coming to physical function. What is the physical function of the periodontal ligament? So we already know that the periodontal ligament acts as a connecting link between the tooth and the alveolar bone. So we can say that the first function is to provide attachment of the tooth to the bone. Then what could be the other functions? It helps in transmission of occlusal forces, which could be the masticatory forces. So any other forces, biting forces to the alveolar bone. Also, it helps in providing a resistance to impactive or rather larger occlusal force. So the periodontal ligament could also be called a shock absorber, and also it provides a soft tissue casing, or rather a protective casing to the nerves and blood vessels, and this prevents the nerves and blood vessels from injury. So these are the physical functions of the periodontal ligament. So coming to the formative and remodeling functions. So we know that there are several functions that we perform, which includes mastigation, parafunction, speech, and other forces which could act on the tooth. So all these forces are being supplied by the, or rather being dealt with by the periodontal ligament. Also, we have orthodontic tooth movement, which is also being dealt by the periodontal ligament. So again, it helps in the formation and remodeling during physiologic tooth movement, then accommodation of occlusal forces, and also during orthodontic tooth movement. It also helps in repair of injuries. Definitely, there will be some injuries which are produced during mastigation or during orthodontic tooth movements. So all this is being repaired and reformed and remodeled by the periodontal ligament. So coming to the nutritional and sensory function, so it helps in supply of nutrients. It has to supply nutrients to both the cementum, the alveolar bone, the periodontal ligament itself, and the encompassing gingiva. So all these receive their blood, their nutrition through the blood supply and the lymphatic drainage. So let's go into detail. So the blood supply of the periodontium is derived mainly from the inferior and superior alveolar arteries, that is, which is supplied to both maxilla as well as the mandible, and they reach the periodontal ligament through 3 main sources. The 3 main sources include the apical vessels, the penetrating vessels from the alveolar bone, as well as the anastomosing vessels of the gingiva. Besides, we also have the lymphatic drainage. The periodontal ligament of the palate mainly drains into the deep cervical lymph nodes, except for the third molars and the lower central incisors, or the mandibular central incisors. Mandibular incisors, the rest of the periodontal ligament fully drain into the submandibular lymph. Also, the third molars drain into the jugulo-digastric lymph nodes, and the mandibular incisors drain into the submental lymph. So we see there are 4 main lymphatic drainage sources, which is the deep cervical lymph node, submandibular, jugulo-digastric, as well as the submental lymph. The nerve supply is mainly supplied by the superior and inferior alveolar arteries, which are branches of the trigeminal nerve. So this is the 5th cranial nerve. These nerves usually pass through the apical foramen of the respective teeth, and they uh, enter into the middle and cervical region through finer branches. These nerves mainly are responsible for the various sensations like touch, pressure, pain, and proprioception which occur during navigation. Now, how does the periodontal ligament maintain its width? So, this is has an adaptability, or rather a capacity to maintain its width at constant dimension throughout the lifetime of an individual. So, this ability to maintain the width is provided by a wide range of regulatory molecules which are present in the periodontal ligament. So, several people have tried to understand or rather study about this the concept of maintaining the periodontal ligament width. And different people have come out with different theories about the maintenance of periodontal ligament width. So, coming to the first theory, the first theory was the tensional theory. According to the tensional theory, the force applied to the tooth would cause the principal fibers, that is the fibers of the periodontal ligament, to unfold and straighten. That is similar to an elastic band. So when a force is applied, it unfolds and straightens, and this force will be transmitted to the alveolar bone, after which there will be an elastic deformation of the bone. That is, it will return back to its original shape. That is similar to an elastic band. This was a tensional theory. And the second theory was the viscoelastic theory, which was proposed by Bien and Byrne in 1966, according to which they proposed that the periodontal ligament was similar to a similar to a fluid with fibers having only a secondary node. So that is when the forces act on the periodontium, the fluid passes out of the periodontal ligament space through the foramina and the cribriform plate, and the fiber bundles will then absorb the shock and they tighten, which in turn will result in stenosis. That is, there will be a cutoff of the blood supply, and this in turn will cause an arterial back pressure, causing ballooning of the vessels, and there will be a passage of blood ultrafiltrate to the tissues, thereby refueling or rather replenishing the tissue fluids. So, thereby helping them to return back to their normal state. This was according to the viscoelastic theory. There's one more theory, which is the thixotropic theory, and according to this theory, they propose that the periodontal ligament behaves like a thixotropic material, or rather a collagenous gel, and that the fibers are only artifacts. So these are the three theories concerned with the periodontal ligament. So coming to the age changes related to the periodontal ligament. So with aging, we know that the forces of mastication, or rather there is a diet restriction. Definitely there will be a decrease in the consumption, food consumption in an aged person compared to a younger person. So due to this restricted diet and due to the decrease in function, the periodontal ligament width will start decreasing in an older individual. So that is a major change which occurs to the periodontal ligament. That is the decrease in the width of the periodontal ligament, and this in turn will result in loss of gingival height, which could be due to or rather related to, or could be caused by gingival disease or periodontal disease. So all this comes hand in hand. So as the individual ages, the width of the periodontal ligament decreases. So coming to the clinical consideration. So what we have already seen, that is, we know that the periodontal ligament acts as a primary supportive structure for the tooth in the bony socket, and its thickness varies. And we know that it's thinnest in the middle with an hourglass shape, and usually it becomes thinner in non-functional individuals or rather older individuals, and that the width of the periodontal ligament increases with excessive occlusal stress. These are the different changes we see in the periodontal ligament. That is depending on the function of the periodontal ligament. Now, other clinical considerations are that when a tooth becomes out of function for a long period and it's adapted to a new function, it takes some time to get adapted to the new functional demand. When there is a demand, it takes some time to adapt to the new function. And also in case of acute trauma, like an accidental blow or rapid mechanical separations or fractures, there will be resorption of the cementum or tears in the fiber bundles, which in turn will result in hemorrhage or necrosis, causing a resorption in the adjacent alveolar bone and widening of the periodontal ligament. So when there is a resorption and widening of the periodontal ligament, it ultimately result in tooth loss. And in case of orthodontic movement, when the orthodontic movement is within the physiologic limit, when there is initial pressure applied, or rather when there is compression, there will be bone resorption on the compression side of the orthodontic movement, and there will be bone apposition on the tension side of the orthodontically moving tooth. So, however, when the force exceeds the physiologic limit, it will ultimately result in necrosis of the periodontal ligament and alveolar bone and result in ultimately tooth. So, when the orthodontic movement is within the physiologic limit, it will result in bone resorption on the side of pressure or tension, pressure, and there will be bone apposition or bone formation on the tension side. Then the periodontal ligament in the periapical area is often the site of periapical granuloma. Here, usually periapical granuloma is usually a sequelae of dental caries, and this periapical granuloma can in turn progress to a cyst, which is a commonly found pathologic lesion in the periodontal area. Another most common pathology is the chronic inflammatory periodontal disease associated lesions, which is a result of the toxins released from the bacterial dental plaque as well as due to the metabolites released from the host defense mechanism. This in turn can destroy the periodontal ligament and adjacent bone, causing tooth mobility and loss. So now several techniques, surgical techniques have been introduced, like guided tissue regeneration for the correction of periodontal destruction, or rather regeneration of the periodontal ligament has been attempted by many. Though they have achieved regeneration in other areas, cemental regeneration is still a distant dream regarding researchers. So, and more recently introduced principle is the tissue engineering principle, which utilizes biological principles like gene therapy and biocompatible scaffolds with growth factors, which is an alternative therapy. And here they use mesenchymal stem cells to regenerate the periodontal ligament. And the periodontal tissue engineering demands the presence of few cells, which includes that is cells which are capable of regeneration. It requires a scaffold whereby the cells can repopulate, and the signaling molecules which favor the multiplication or regeneration of the cells, and it also requires adequate nutrition which can be provided by the adequate blood supply in the area. So this is a area of research, and there's been several ongoing researches in this field of regenerative medicine, and we are soon hoping to achieve good success in this area. So with that, we come to an end of the periodontal ligament session. So I hope you've picked up a few points on the